Okay, very good. So we wanted a chance to be able to get the group together, talk and learn from each other as we're doing this. And so although we're going to have some presentation, we also want to save plenty of time for discussion or questions. So at least for me in my talk, as I'm going through, if anyone has any questions, please stop and interrupt me. We've got a great lineup for the day. I think you saw the agenda a little bit earlier, but just to go back over that a little bit, I'm going to take just about 15 minutes or so to be able to go through and give you some updates in terms of everyone who's been talking with Ashley Wilson, one of my genetic counselors, and what we've been learning. Marissa Mitchel is going to be talking about communication surveys and skills. And then Dr. Sid is going to be talking to us about medications. And again, we'll have interspersed some time for questions after each of the talks, or even in the middle of my talk at least, because we didn't really put time after that. At the end of this, what we're going to do is basically let the families, we're going to, as professionals, we're going to get off the line, we're going to stop the recording, and then we'll let the families have some time to talk with each other about anything you like, either what you've been hearing or anything that you'd like to share with each other. But we'll let you we'll keep the line open and you can spend as much or as little time as you'd like to together. Okay, so I'm going to start, and some of you that were here last year will recognize some of these things. Lindsay, I'm going to let you control if that's okay, and I'll just have you say next slide, or I'll say next slide rather. So this is fundamentally, HIVEP2 is fundamentally a genetic condition. I realize everyone on the line knows this, but it's sort of constantly amazing to me that there's, for your kids, there's just one teeny tiny little change, 1 out of the 3 billion letters that cause the change that we're seeing with them. Next slide. As we're seeing this, and anyone feel free to correct me if we've gotten this wrong, there are 7 families or 7 individuals that we're going to be talking about today who've been kind enough to tell us about their information. In all of the families except one, this was what we call a de novo or a new genetic change. And I'm sorry that something got whited out here on the slide, but it's a new genetic change that was not present in either parent. To my knowledge, there is one parent who has a small number of cells who has this change, but for all the other families, this is something that started brand new. And just so everyone knows, this is something, these brand new genetic changes are something that happen with all of us when we have children. There are about 100 such changes in every child that we have. It just so happens that for your children, it fell within the HIVEP2 gene, as opposed to for your other children, or some of my other children, for instance, they have changes, but it just didn't happen to fall either in a gene at all, or at least not in a place in a gene that mattered. And that's why we might not see any manifestations. Next slide. So I'm directing this to the moms, but dads, just in case you were having this concern also, there's nothing that anyone on this call did or didn't do to cause this. This wasn't something that you didn't take your prenatal vitamins, moms, that you had a glass of wine before you realized you were pregnant, that you missed an appointment or got sick with the flu. None of these things caused the HIVEP2 change. These are things, as I said, that happen with every single pregnancy, at least some new genetic changes. We can't always pin down exactly where it happened. If it happened in the egg that ultimately made your child, or the sperm that made the child, or after the two of them got together. The genetic testing that you had actually doesn't tell us that information. But the good news about the fact that it did happen new means, for those of you that are thinking about having additional children, there's a very small chance that it will happen again. It's not 0, but there's only about a 1% chance that it will happen again, as long as the parents' testing didn't show the HIVEP2 change. Next slide. So within this, and I apologize about the alphabet soup, but I wanted to help the families understand the actual genetic changes. So these are the different mutations or the different genetic changes in HIVEP2 across the families. One of the things you will see is that if you look at the column in the right for number of individuals, each one of you as families are unique. That is, you each have different mutations. On the other hand, one of the things that you may notice on the left is that I'm just going to teach you through the nomenclature for this. The protein change is the P dot or protein dot, and then it shows the amino acid. There's a single alphabet sort of symbolization for the amino acids, the position or the address. So in this case, D, and the address is 397. And then if there's a change, in this particular case, there's a Y at that position instead of a D. One of the things you'll notice for many of the families is it ends in X. For those of you that have mutations that end in X, what happened in those cases is it stops the protein. So in the second line, for instance, the protein, there are 943 amino acids that are made, and then all of a sudden it stops and nothing is made after that. Fundamentally, all of you who have these X's at the end, we think probably behave the same. So even though the X is in a different position, for a complex process that we call nonsense-mediated decay, which you don't need to worry about, but we think that that protein essentially doesn't exist in the body. And so that the mechanism or the reason the children look quite similar is because instead of having 2 copies of that gene that work, they basically all have just 1 copy of the gene that works. And 1 is not enough to be able to do the regular function of that gene. Next slide. So we're going to talk today about all of the families that have provided information. I'm not going to single out any one family. If you want to self-identify and share that information, that's wonderful. We appreciate that, and I think it's helpful for the discussion. But within what I'm going to talk about, we haven't revealed anyone's name or identifying information. As I said, this is based on 7 families that shared information with Simon's VIP. I want to just let you know that this information, de-identified, so with no one's information, is freely available to the scientific community. Any scientist who would want to work on HIVEP2 is able to get this information and hopefully learn from it and help us to understand HIVEP2 better. So we've tried to make this, like I said, make your investment, if you will, in providing this information scalable so that many, many people can get it. This is the group that are represented are about equal, boys and girls, 3 males, 4 females, and span an age range from just under 3 years to 11 years. So notably, and one thing to realize is we still don't have in the group any adults, for instance, with HIVEP2. It's not that I don't think there are adults out there with HIVEP2, but if you can think back to how you got tested, for each one of you, you had a genetic test, and there was one of the doctors, either your geneticist or neurologist or like some sort of other developmental pediatrician or someone that helped you get the testing. In many cases with adults, I think they just don't know about the tests and aren't getting the testing, but it's not that I don't think there are many, many more people out there with HIVEP2 than we realize. So this is, I'm sure, just the tip of the iceberg. Next slide. So within this, the one thing that's common to every single individual with HIVEP2 that we've seen, and this is no surprise to everyone on the call, is that this is a condition that predominantly affects the brain. It affects the brain in terms of development and behavior, ability to speak, ability to be able to do a lot of the things that we do on a daily basis. Not to say that this doesn't get, that children can't learn, they can't master things. They certainly can, but it takes a lot more repetition. And again, I know I'm preaching to the choir for this. One of the things that I want to be clear about is that with this, speech, I think, is something that's, if you just hearing you guys this afternoon, language is certainly a challenge. Different kids are at different phases in terms of learning to speak, but they can. And one of the things I think many of you are working on is being able to use other means of expression besides literally speech. And I definitely want to encourage that. We'll hear more about that, but I definitely want to encourage that because the kids have, I know, a lot going on in their heads that they want to be able to tell us about, and it's important to give them a way of expressing that. At least just for me listening to you, one of the things that struck me is how many parents said that their children are so friendly and outgoing and say hello and are really engaging with others. And I think that's one of their strengths. So I want to emphasize that as well. There are some of the children who've been labeled either with having an official diagnosis of autism or have some overlapping features with autism. My guess is that it's not really those social aspects that we're seeing that overlaps with autism, but more of the language challenges. So when you see that and when you get that label, I don't want you to, be overly concerned. I think there are some overlapping features, but I don't think this is necessarily what some people would think of as a very, very classic form of autism with the social dimension. There are also some other challenges with kids being on the go. That sometimes means that they're very active, sometimes, like really active, and difficulty sometimes with being able to focus or attend to things. And so some children have the diagnosis of attention deficit disorder or hyperactivity. Okay, next slide. And like I said, feel free to stop me at any point as we're going along. And if anyone's typing in or chatting in questions, Lindsay, just feel free to interrupt me. So what I did want to go through, and let me also emphasize one other thing, that the children are not regressing. So the children are not going backwards. They're not losing ability. It's forward progress. It's slower, but it's forward progress. So I'm going to next transition and talk about the medical issues for the children with HIVEP2. Next slide. The good news is, for the most part, there haven't been significant medical issues. I did hear of one exception as we were talking this afternoon, but for the most part, they haven't been significant medical problems. In the newborn period, and obviously some of you are closer and others farther away from that, but if you think back to what you told us about the newborn period, the transition was not too terrible. There was a little bit of transition, a little rockier for one person, but otherwise not too terrible. There was one child that required hospitalization in the neonatal intensive care unit. On the other hand, most of the other things were relatively mild, in the sense of jaundice is when the babies are yellow and have problems with their bilirubin. That usually resolves by itself. One child that had low blood sugar, but overall, nothing too terrible as we were talking about the newborn period. Next slide. Some of the things, though, that were more consistent were problems in terms of tone, having low tone or being floppy. And that's I think, consistent problem for the children even after they're out of the newborn period. Some problems in terms of feeding or just, and I think this is easier for parents who have had another child, maybe some differences in temperament, being a little bit either sleepier or a little bit more irritable. Next slide, with the neurological issues. So some of the, as I said, the main issues are around the brain and the brain function. And so this can, besides the low tone or the hypotonia, can also manifest in some other gross motor skills or movement problems. So several of the children are a little bit clumsier. They have difficulty with coordination. They're not so smooth or graceful. They're learning to move their body. They're figuring out where their body is in space and figuring out that coordination. And it's taking them longer to put all those pieces together. So that tends to manifest as being clumsier, bumping into things, not quite, having it together in terms of those movements being well coordinated. 3 of the children were diagnosed with cerebral palsy, or CP. That's, to me, a term that sometimes gets used relatively loosely. And so, to me, cerebral palsy is really caused by having problems with not enough oxygen to the brain at the time of delivery. And my guess is these are not truly cerebral palsy, but problems that are manifestations really of HIVEP2 that look a lot like cerebral palsy. And so that's why the children have gotten that diagnosis. Next slide. The good news is that seizures have not been a significant problem. There is one child who's had one full-blown seizure or grand mal seizure, but again, it hasn't been a common problem. The one limitation I will say is, I think we just heard about one, but most of the children have not started making the transition yet to puberty. And that is a time where sometimes we see seizures come up again. So sometimes we see them when they're little ones, and then another area or another time of life when this can come up again is during puberty. So I do want us to continue to pay attention. I'm hoping we're out of the woods for most of the kiddos, but I think it's something we need to continue to pay attention to. And I'll just remind you that if you do see anything like either a jerking movement that you're worried about with seizures, or your kids are zoning out with what we call petit mal or absent seizures, if you're worried about it and you happen to have your phone with you, take a brief video of that and show your doctor. If you have a neurologist, show your neurologist. That can often be very helpful to understand exactly what you're seeing when we can see the same thing. But so far, not a common issue. Next slide. What has been more common, although not debilitating, has been vision problems. I do think it's a good idea for all the children, if they haven't already been checked, to have their eyes checked, and if there has been a problem, to regularly see their ophthalmologist. The reason I say that is because we need to have all their senses working as well as possible so that we can make sure they're taking in the world as accurately as possible. So to me, that means making sure their vision is good, making sure their hearing is good. We don't want any barriers to them to be able to learn and experience things accurately. So with these, all of these things are things that can be taken care of. Strabismus or a lazy eye can be taken care of either with patching or surgery if necessary. Being farsighted or having an astigmatism with glasses lots of the time. So these are things that are treatable, and obviously we want to do whatever we can to treat what we can. Next slide. In terms of gastrointestinal or tummy issues, the children do have some problems. It's having low muscle tone, not just with the muscles like the arms and the legs, but also having low muscle tone essentially within the intestine, I think is part of what we see with reflux or heartburn. And that can be an uncomfortable feeling, and it's very easy to treat. And so for the children have been treated with heartburn or reflux at some point. When the muscle tone is not so good, it also means that things don't always move through the system, through the intestinal system normally, and so that can sometimes manifest either as constipation or as diarrhea. And with some children, it actually alternates between the two, sometimes constipated and sometimes diarrhea. Lots of times that can be managed either with diet or some relatively simple medications, but it can be uncomfortable, if it is an issue. So I know it's hard sometimes to tell what's an issue and what's causing it, but this can be something, that can cause problems. And again, talk to your pediatrician oftentimes can be very, very helpful here. Next slide. I think we heard about it a little bit in the introductions, but ear infections in particular are quite common. Just so everyone knows, and those of you who have other kids know, ear infections are common with all kids, so it's not necessarily specific to HIVEP2, but there are a few more ear infections than we see in the general population of kids. And again, for those of you who have had kids with many ear infections, some of you have needed to have ear tubes to be able to drain the fluid from the ears, because we want the kids to be able to hear well. We don't want them to feel like they're underwater and they can't hear. Not very common, but urinary tract infections, another type of infection, and all of these are very easily treated with antibiotics. So these are not difficult, neither one of these are difficult things to treat. Next slide. Lung issues or pulmonary issues are not common. We've had 2 children with asthma, and again, asthma is a pretty common thing in the population. So I think this is really probably about the same as what we see with the general population for asthma. And then in terms of heart issues, we have had 1 child with a murmur, and we just heard about Eli this afternoon, who has a type of congenital heart disease. It's not very common in general, but my guess is, and we see this with some other genetic conditions like HIVEP2, it's about, I'll bet you at the end of the day, it'll be about 10% of kids that'll end up having something like congenital heart disease. Relatively infrequent, but I do think it's related. And that's based on some, other things we know about, that I know about congenital heart disease. Next slide. And that, I think, Lindsay, was just the heart issues. So if we could go on to the kidney issues. So in addition, in terms of kidney issues or urinary tract issues, not common, but we have had 1 child that had problems with the urine that sort of went backwards up into the kidneys. That's something that, again, can be relatively easily treated. We especially want to make sure that individuals who have infections, urinary tract infections, don't have that urine with the bacteria going back up into the kidneys, because that can cause infections in the kidneys, which are a little bit more serious. So again, very easy to treat and thankfully not very common. Next slide. In terms of what we call hormonal issues or endocrinological issues, there have been a couple kids who've had some problems gaining weight. Just looking at the beautiful picture of your children, it doesn't look to me like anyone is too terribly thin, but some kids can have some issues either just because there are feeding issues or intestinal issues, or they just may be on the lighter side. You know, not everyone is going to be a big, tall kid. So this isn't very common, and to my knowledge, anyone can tell me differently, but to my knowledge, no one's needed anything like growth hormone or any other types of endocrine treatments. Next slide. For bone issues or orthopedic issues, a lot of the children have braces or AFOs or things to help in terms of some of their orthopedic and their hypotonia issues, but there haven't been any too serious issues yet, just one child with hip dysplasia. But I will say that again, our children are still pretty young, and I want you to pay attention as they get older for scoliosis or curvature of the spine, because that is something we see more frequently in children with neurological conditions, and our kids are still kind of young. Okay, I'm going to go the next slide rather is surgery. And I think we talked about most of these before, but these are things that are taking care of either the ear infections or the eye problems. And relatively, the most common of these has been the ear problems or the ear tubes. And sometimes at the same time, they'll take out the tonsils and the adenoids and do that all as one surgery. Okay, next slide. In terms of skin issues, I would say that these are kind of the typical things that we see for children: a little bit of eczema or a little bit of dry skin. A hemangioma is a little blood spot on the skin, a little vascular or blood vessel change. Again, I don't know that any of these is necessarily specific to HIVEP2. A cafe au lait spot is just a little spot that looks like the color of coffee with milk. And keratosis pilaris is it looks like a little bumpy rash. It looks kind of like red goosebumps on the skin. None of these serious, none of them debilitating. Okay, so rounding up, go ahead.
All right, we just had a quick question asking if you could clarify your estimate about 10 children with HIVEP2 possibly developing heart conditions. Just clarify on that and see if it's making the parents should look out.
Thank you for that. So I may have said this incorrectly. What I meant to say was that I think at the end of the day, when we have enough children with HIVEP2, I'm expecting that the frequency will probably be 10% of all children with HIVEP2 will have congenital heart disease. Our numbers right now are running 1 out of 7. So, but our numbers are very small. So, but there are several other neurological conditions that are like HIVEP2 where and those sizes have been larger. They've had more children in those other groups, and we've been seeing about 10% of those. And so it's a guess. I could be wrong at the end of the day, but I think that's probably what it's going to be. If your kids haven't had an echocardiogram, I would say it's a good idea to get an echocardiogram, do more than just listen to the heart with a stethoscope. But if they've had one echocardiogram that's normal, I don't think they need to get it repeated, because these, as far as we know, are structural heart problems that the children were either born with and had or didn't have. So I don't think it's going to come later. But, we don't know everything, but it's not something I'd expect would come later. Okay, I hope that answered the question. I'm going to go to the slide on medication use. So folks have needed some medications. The one child with seizures has needed medication for that. As I said, some intestinal issues for constipation or reflux needed medication. And then we oftentimes see either for kids that have behavioral issues, ADHD needing medications, or sometimes sleep. Melatonin commonly used, but sometimes something stronger can be needed to help with the sleep. And I will say that good sleep is necessary for good learning, and so important to try and get a good night's sleep, all of us, but especially our kids with HIVEP2. So just in summary, the children have consistently some problems with developmental delay, but no regression, importantly. And the other medical problems, for the most part, for most of the individuals, have not been serious. I'm not saying they're not important. I'm not saying we don't want to treat them, but they haven't been life-threatening problems. They haven't been serious problems. The one challenge, I think, in terms of health issues is just that when something's wrong, the kids have trouble telling us what it is and where it is. And so I think that's what, in terms of anything that's life-threatening or problematic, that's when I get concerned in terms of being able to just make sure you know your kids. And if you really know something's off, just advocate for them. And, make sure you tell your pediatrician, make sure you tell the emergency room docs that you know something's wrong, even though you might not know what it is, that you know something's wrong. Okay, so I'm going to stop there. I think in terms of things, I have some slides here, which I had also talked about last year in terms of gene therapy, but I don't want to take up all the time. If parents have questions, I'm happy to go over this, but what I want to briefly say is that gene therapy is certainly moving along nicely. Just this week in the New England Journal of Medicine was a very nice update on a clinical trial of gene therapy for a completely different neurological condition, but one called spinal muscular atrophy that showed very promising results. So I'll just say that in general, gene therapy, gene editing is certainly moving along nicely. It's not trivial. It's not easy. We don't know yet that it's perfectly safe. So I think this is something to continue to pay attention to and stay tuned. We don't have the answers yet, but I do hope that it's going to be something in the future that's going to hold more promise. And it's something that we definitely, should be paying attention to and keeping track of. The other thing I'll say is that, let's see. Just trying to look. So on the next steps, as we're doing this, one of the slogans I know some of you know I say is the care until the cure. I think there are lots of things we can learn from each other in terms of doing this. And at the same time, one of the things at the Simons Foundation we're trying to do is to find researchers or provide funding for researchers who are interested in studying conditions like HIVEP2 and making sure everything that you've been providing, if you provide blood samples that we can make cell lines from, or information, or eventually mouse models for this, that we can almost package this up to give to the research community so that it makes their life a little bit easier to do the research. So I don't want to eat into Marissa's time because I know I've already started doing that. So I'm just going to stop and see if there are any burning questions and then let Marissa talk about some of the other topics for this afternoon. Okay, so Marissa and Narissa, a great combo, are going to do the next part of this on communication. I'll turn it over to you guys.
Okay, can you hear me okay? This is Marissa Mitchell.
Yes.
Okay. And Narissa, are you on the line also?
Yes, I am.
Okay, so Narissa, I would just say feel free to chime in at any point if you have anything to add. I know that you helped to develop this survey, so if there's anything that you want to clarify or anything you want to add, please just stop me at any time, okay?
Okay.
Okay, now let me see if I can try here. That worked. Okay. So the total number of participants who ended up taking the survey were 5 families. So thank you so much for participating. This is really helpful to get this information. The age of the children who took part in the survey were 4 to 11 years, which corresponds to pre-K to 6th grade. And I think it's important to keep in mind the age range of children because some skills I think that we're asking about wouldn't necessarily be expected of the younger children. So that's definitely something to keep in mind. Types of special education services, I think the most commonly reported one is a full-time self-contained classroom. It looks like 4 out of 5 children reported that. And now all of these numbers will not add up to 5 because families could indicate that their child had at some point received more than one type of service or placement. So the full-time self-contained classroom was the most common. Some children also are in mainstream classrooms with paraprofessionals or aides. Others have resource rooms or learning supports. And then 2 children reported ancillary services, so speech, occupational therapy, and physical therapy. For some reason, my arrow keeps, there we go. Okay. The children, I think that the take-home message is that the children really do display a wide range of proficiency in their use of different types of communication skills surveyed. So 3 out of the 5 children who took part in the survey did report some speech to communicate. Among those 3 children, the articulation ability, so the pronunciation ability of those children varied. So some children are highly intelligible to others, whereas other children maybe would be very difficult to understand unless you know them very well. Overall, the children surveyed do tend to require less support in their use of communicative gestures relative to other means of communication. So other means of communication being things like speech or picture exchange systems, speech generating devices. It seems like gestures comes more naturally to children. 2 of the children reported using manual picture boards, picture exchange systems, and speech generating devices. Among those different types of systems, the children need differing levels of support. So some were more independent in their use of these systems than others. And then 3 of 5 children have used sign language at some point as well. All 5 children who were sampled can sometimes or almost always respond to their name, understand no, point to pictures in a book and parts of the body when prompted. They can follow familiar single-step directions, both with and without accompanying gestures. And then they understand and respond to simple who, what, and where questions. So these are all skills that we would consider receptive language skills or comprehension skills. And then most of the children surveyed also can sometimes understand novel directions without accompanying gestures, so new things that they've never heard before. And they can also follow verbal directions involving more than one step. Interestingly, 3 out of the 5 children, which would be 60% of those surveyed, did report experiencing a loss of language or other skills. So all 3 children who did report this reported that it occurred with speech specifically. Some also reported that social skills or nonverbal communication, things like eye contact or responding to name, also they experienced regression in that area. And then 1 individual reported a regression in gross motor skills. Of the individuals who did report the loss of skills, the loss ranged from mild to moderate. One of the questions asked if these losses occurred that corresponded with things like fever or illness or hospitalization. No one reported that that was the case. 2 of the 3 kids who experienced the loss have since regained those skills. The skills were regained between 12 and 24 months. Several of the questions dealt with what's called augmentative and alternative communication, or AAC. I'll be talking more about AAC in the second part of this presentation. So if there are certain terms that you're not entirely sure what they mean, I hope that I'm able to clarify that later on. 2 of 5 children indicated that they used a speech generating device. The symbols that those children used, they used with varying levels of consistency. So it looks like 2 of the children almost always or sometimes use familiar objects. 1 child was able to use photographs. 2 children were sometimes able to use everyday symbols, and these could be things like probably board maker symbols, maybe recognizing logos, things like that. And then 1 child, some of the time, was able to use letters. And this is a note about AAC from a fellow HIVEP2 parent. My son has excelled in communication. And Marissa, actually jump in. Is this your quote? I think you had mentioned pod before.
Yeah, it's us.
Okay, do you want to go ahead and jump in and talk a little bit about that then?
Yeah, sure. So we started using pod with Corinne back in June, and we weren't really getting anywhere with many of the other techniques we were trying. He did not do well with PECS, picture card exchange. He was more interested in like swiping those cards or banging them together. He didn't really seem like he was interested in using PECS as a form of communication. And so the pod book, the format that we're using has 12 symbols per page. And when he started using the pod book, that's when he started pointing, and that skill started emerging. And he's rapidly improved his communication abilities, and he's even going beyond requesting, and he's commenting and protesting some. So we're super thrilled with how much progress Kern has made with this specific approach that works well for him given his sensory and motor challenges.
Thank you. And I will also, later in the presentation, I'm going to talk a little bit more about POD in more detail. So thanks for chiming in. Oops, let me try that again. Oh, go back. Okay. Reading development. So one child reported some pre-reading skills, and 2 children reported actually reading. And the children who reported reading are between the ages of 7 and 11. 3 children reported print awareness, so an understanding that letters make up words or what letters are. 3 also reported an awareness of sounds in speech, so that's things like rhyming and understanding how sounds fit together. 2 children reported some alphabet knowledge. 2 children also reported sound symbol correspondence, so that's understanding that letters make sounds. 2 children are able to actually begin decoding in their reading, and 2 children also have some word recognition, so that's probably sight words is what that means. Spelling skills, 2 individuals were able to use 1 to 3 letters to spell words, and then 1 child is able to spell words as they sound. Writing skills, so 3 out of the 5 children are able to make marks on paper. 1 child demonstrates an intent to communicate in writing. 2 children reported printing all letters of the alphabet, as well as being able to print their first and last names. 1 child can use writing to label pictures, and another can produce conventional text by copying dictation. Okay, so that concludes the first part of the presentation, which was going over the results of the survey. The second part of the presentation, supporting communication skills for individuals with HIVEP2, I'm going to be talking mostly about augmentative and alternative communication strategies, or AAC, since it sounds like many of the children in this group have benefited or could benefit from using AAC strategies. So a brief overview of what I'll talk about. The first is, what is AAC? And I think many of you have probably heard the term before and might be surprised to hear that it encompasses, more than just speech generating devices or pictures. For those of you who are interested in pursuing some additional AAC strategies for their child, I will talk about how to go about doing that through the assessment process. And last, I'm going to be answering some questions. So the way that I've put it in the presentation is in the format of frequently asked questions. These are questions that I'm probably asked by parents the most often, which may or may not also apply to your kids. And I also know that parents had submitted some questions in advance of this presentation, and I did try to include some of those in this format in a more general way. However, if there are specific questions that I'm not able to address during this presentation, I certainly want to leave time for parents to ask those at the end as well. Okay, so what is AAC? I think most of you can recognize this person. This is, of course, Stephen Hawking, the world-famous physicist from the UK. He has ALS, or Lou Gehrig's disease, and so for a number of years now has had to rely on using a speech-generating device. So I think when a lot of people picture AAC, this is the type of AAC they think of. They think of some type of a high-tech speech-generating device with a kind of robotic sounding voice to it. And that is a type of AAC, but AAC is much broader than that. So it refers to all tools and strategies that are used to supplement or replace speech when it's not sufficient to meet a person's daily needs. And I wanted to highlight a few parts of that definition. So first, the tools and strategies part. So AAC, yes, it refers to tools, things like devices or pictures, but it also refers to strategies, so the way that people can communicate more efficiently and effectively. And then the second part of the definition I want to point out is that AAC can be used both to supplement as well as replace speech. So I think some people, when they think of AAC, they think it might only be helpful for individuals who are nonverbal. But that's just not the case. And I would actually hazard to guess that most individuals who use AAC actually do have some speech. The underlying concern, though, is that the speech isn't sufficient to meet all of that person's needs. Maybe their speech is difficult to understand. Maybe they just don't have enough words to adequately convey their thoughts. And so there are a lot of individuals out there, a lot of children out there who might benefit from AAC who aren't currently using it. So what kinds of children could benefit from AAC? The short person is there really is no typical user. There's a really wide range of individuals who benefit from it, from intellectual disability, autism spectrum disorder, to kids who have motor difficulties, So cerebral palsy, motor speech impairments, kids whose speech is highly unintelligible, and then individuals who also have craniofacial differences. So things like cleft palate can be very hard to understand. So in general, anyone who can't rely on speech alone to meet their needs. It's a very wide group. AAC can be divided very generally into two fields. The first is unaided strategies. These are things that don't require any excess tools. So the user uses his or her own body to convey the message. It includes facial expression, vocalizations, gestures, and sign language. And I think as part of the survey, many of you mentioned that your children are currently using gestures well, and that's great. That would actually be considered AAC because it's supplementing speech. Sign language too, I think 3 out of the 5 children also reported using some sign language. And then the other broad category is aided AAC. Aided meaning some type of a tool is necessary to convey the message. Aided AAC falls somewhere on a continuum from low tech to high tech. Low tech could be things like pencil and paper, alphabet boards, pictures, photographs. Both PECS and POD would be considered low tech strategies. And then as you kind of move up the continuum, you have mid-tech devices. These can be things like single message voice output devices like a Big Mac, fixed display speech generating devices like a GoTalk, or high-tech devices. Now these can be dedicated devices or they can be non-dedicated tablet-based devices such as the iPad. So I'm going to go over 5 different types of AAC. This is certainly not a comprehensive list. There's many more strategies than this out there. But in my experience, these are probably the most commonly used strategies. The first is sign language. I think the first thing, an important thing to keep in mind is that American Sign Language ASL is a real language. And what I mean by that is, you know, there's thousands of words in sign language. These can be combined in really an infinite number of ways. There's generative grammar rules that are involved. And so, you know, individuals can have entire conversations using ASL the same way that we would use spoken English. Before about 1990 or the early 90s, it was actually the most common AAC strategy used for people who have autism or intellectual disability. I'd say starting in the 90s, things like PECS and then speech generating devices began to become much more popular. But traditionally, for individuals who are minimally verbal, sign language was the AAC strategy to use. Some researchers and some teachers would argue today that it's still easier for certain individuals, particularly with intellectual disability, to learn signs versus picture selection. Although in my own experience, I would say, you know, some children respond better to one and some respond better to the other. And then sign language is oftentimes most effective when it's used in what's called a total communication approach. And that's where you use both sign and speech simultaneously to communicate with the child. There's been research studies showing that this actually aids the child's comprehension of speech as well as their ability to produce it. So just like any type of a strategy, there are going to be some pros and cons. The pros for sign language, the first is big in that it's a true language, meaning that there's an unlimited generative vocabulary. It's also portable. You could say it's infinitely portable in that a person always has access to his or her hands. It's inexpensive. So unlike equipment that sometimes costs thousands of dollars, most people can learn sign language by taking a basic class. There are books, there are videos out there that families can learn on their own. And then the last is that it's a relatively fast rate of communication. So individuals who become proficient with sign language really can communicate just about as fast as speaking individuals. The negative aspects of sign language, I think the first one is probably the biggest one, and that's not all communication partners, and actually most communication partners probably will not understand a child's signs. This is less of an issue at the early ages when children are mostly coming into contact with their own family members, teachers, therapists who do understand sign. But as children become older, it could become more of a problem. So most people in the community are not going to understand sign language, and so they're going to have to rely on people to interpret for them. There are a lot of learning demands that are placed on the communication partners to learn sign language. And one thing that's important too to keep in mind is that the family members and the therapist will always have to be one step ahead of the child. So children learn from imitation and from modeling most of the time, and so they have to see new signs actually modeled for them in order to learn new signs, otherwise their language growth is going to plateau. And lastly, for many kids, sign language just might not be a possibility if there are significant motor impairments. PECS is another very commonly used strategy. PECS stands for the Picture Exchange Communication System. And it's actually based on a training protocol from the mid-'80s based on the principles of applied behavior analysis. And I would say at least half the time when I hear families or schools saying that their child is using PECS, they really just mean that their child is using pictures to make choices. And I think that's erroneous much of the time. So PECS really does refer to a very specific training protocol. It doesn't just mean using pictures to make choices. In the true PECS protocol, there are 6 different training phases. The first phase is really just teaching a child how to communicate. And that might sound very obvious, but for many children, particularly children with autism, that's not that obvious. Kids do have to learn that communication is an exchange and that it always happens between at least 2 people. That in the first phase of PECS is taught very explicitly. Basically what happens is the child sees something that they want, they reach for the item because that's the child's natural response, and then that reaching behavior is shaped into an exchange. The second phase of PECS, the child still has access to just 1 picture at a time, but then they have to learn, okay, sometimes the person in front of me has what I want, sometimes I might have to walk across the room and find the person who can get the thing that I want, and so it really teaches persistence. It's not until phase 3 of PECS that a child has access to more than 1 picture at a time. That's called picture discrimination, and I think commonly most people refer to that as choice making. So when I see PECS fail, most of the time it's because I see people skipping right to phase 3, where they're giving a child access to multiple pictures and asking them to make a choice. Many kids aren't ready for that yet, and so they're not going to learn how to do that functionally. The last 3 phases of PECS teach children to do things more than just request. So things like actually putting words together to form a sentence, answer questions, and comment. The pros of PECS, number 1 is that it's durable. So unlike a high-tech device that can break if you drop it, PECS is made out of inexpensive paper that's usually laminated and Velcro, and so it's pretty hardy. If a child does, flush a picture down the toilet or drop it out of the car, it's fairly inexpensive to replace. It's also easy to understand the message. So this is in contrast to something like sign language, where you need to be trained to understand what a sign means. I think most adults, if they were handed a picture of a cookie by a child, they would understand that that child is requesting a cookie. There's also research support, quite a bit of research support for kids who have autism as well as other developmental disorders in supporting the use of PECS for basic communication. Some negative aspects is that vocabulary and language complexity are going to be constrained. So PECS is really great for teaching requesting. It's not really great for teaching how to combine words in a novel way, in a grammatical way. Secondly, there's no voice output. Certain situations, you might want voice output to get someone's attention or to communicate from a distance. There's going to be a slower rate of communication. So, as the child gets better at using PECS, ironically, they're actually going to get slower at using PECS. They're going to have access to more and more pictures. It's going to take longer to find what they want, and it becomes more cumbersome. It's harder for them to carry around all those pictures with them throughout the day. POD is the next low-tech system I'll be talking about. It stands for the Pragmatic Organization Dynamic Display, and this is the system that Marissa was mentioning that her son is using successfully right now. This strategy was developed around the same time of PECS, actually, in the 90s in Australia by Gail Porter, and at the time it was really designed mainly for children with cerebral palsy who lived in residential or special schools. I'd say just in the last maybe 5 years, POD has really taken off in the United States and become a lot more popular, but it has been around, especially in Australia, for quite some time. It's a multi-level low-tech system involving what they call partner-assisted navigation. What partner-assisted navigation means basically is the child points to a picture in the book, and then the adult then flips the page to new vocabulary based on their selection. So for example, maybe the child points to something is wrong, and then the adult would then flip to the vocabulary where they could tell you what's wrong. So, my head hurts or my stomach hurts. It's based on the principle of aided language stimulation, which basically means that children learn best through modeling. And so the primary teaching principle of POD is that the adults in their environment will actually be using the POD system to model good communication skills. The pros of POD are that it encourages communication for a variety of pragmatic purposes. So I mentioned with PECS, especially the early stages, you're really focusing on requesting almost exclusively. With POD, the child is able to request, but they're also able to comment, to ask questions, to protest. We all communicate for different purposes, and POD really supports that. It also grows with the child over time. I think Marissa mentioned that her son is using a book with 12 items on a page, but if I go back real quick to this slide, you can see that it becomes a lot more complex over time, where you can actually have access to dozens of things per page. There's a large amount of preset vocabulary, including core words. Core words are those little function words that actually make up the majority of speech, so things like the and for and to. And then it can be adapted for children with severe motor impairments. So some children might have difficulty with a true touchscreen device because they lack the precision and finger control. POD, if you kind of get in the ballpark, your partner can help you and figure out what you're trying to say. Some negative things about POD are that it will always require adult assistance. So when a child does make a selection, it does require that their partner flips to the page that they want. Again, this isn't an issue when kids are younger, and most of the people who they're talking to are adults or family members. But as children are older, it will require an adult to be there with them as they communicate, for instance, with peers. It doesn't have voice output like the other strategies. There are certain situations when you might want that. It's a slower rate of communication, again, because you have to touch the picture and then wait for the adult to go to the next page that you want. At this point, there really isn't a whole lot of research evidence on its efficacy. And I want to stress that doesn't mean that it doesn't work for some kids. I've certainly seen it in practice work very well for certain kids, but I do think it's important that more research is done to try to figure out which kids are going to benefit best from the strategy and how to implement it effectively. And then lastly, in my own experience, again, there's not research on this, but in my own experience, I find that POD doesn't work as well for kids who have difficulty paying attention to others or have difficulty modeling. Again, because the teaching strategy is mainly modeling and aided language stimulation. If a child doesn't really take to modeling, if they need something a little bit more directive, sometimes POD can be challenging.
Marissa?
Sure.
I just wanted to add too, these are all the low-tech options for POD, and there's actually 2 high-tech options. You can use POD on an iPad through the Compass app, and then POD can actually also transfer into a speech-generating device through Tobii Dynavox.
Thank you. Yes, that's true. And those are recent developments just within the last year or two that they've really brought that to speech generating devices. So that has been helpful. Kids who are used to the low-tech system, but who are ready to transition to a high-tech system, it certainly provides an avenue to do that.
Yeah.
Thank you for adding that. The next type of device I'm going to talk about is a high-tech device, fixed display speech generating devices. Now, I have a few examples down here. These vary quite widely in terms of specifications, complexity, and price. So all the way on the left, you see what's called a Big Mac device. And that's basically where you record a single message, the child hits the button, and then it plays back the message. These can also go up to, like the Go Talk type of devices, touch tech, things like that, that might have dozens of messages per page. They do get more complex than that. The pros are that they're relatively cheap. When you compare them to high-tech, tablet-based devices, these are usually $100 or several $100s versus several $1,000s in the high-tech devices. They're durable, so like touchscreen devices, obviously, if you throw it, the screen could break and shatter. These devices are really used to taking some wear and tear, so you can usually drop them. I've had kids actually slam tables on them, and they don't break very easily, so that's one benefit to them. They're relatively easy to program and use, and then they do have voice output. So this is an option for a child who would require voice output for some situations, but might not be ready for a dynamic display device. The cons, and the first one's a big one, is that vocabulary capacity is very limited. So I very rarely recommend a fixed display SGD as an individual's primary communication strategy. I will sometimes recommend it as a supplement for something else, just to give the child access to voice output. But in general, when you give a child a fixed display device, you're only giving them access to a very small set of messages that they can use at any one time. Typically, they do require adult assistance to switch out overlays. So let's say you give a child access to snack vocabulary during snack. When that child then transitions to circle time, an adult has to be there to switch out and give them access to new vocabulary. So it does kind of limit independent communication. Dynamic display SGDs are high-tech devices, usually tablets nowadays, almost exclusively tablets nowadays, and these change screens when activated, thereby introducing new vocabulary. I think pretty much everyone there either has or has at some point used iPads or tablets or smartphones, and so they're generally familiar with what it means to have a dynamic display device. On these devices, vocabulary is usually represented by photographs, pictures, words, or both. And then vocabulary can be arranged several different ways, most commonly by grid displays, and you can see that down on the bottom left-hand side. That's a typical grid display. Another way vocabulary can be arranged is by what's called visual scene display, and that's an example of that is on the right down there. Visual scene display is usually where you take a photograph of a single thing, maybe it's a room, it could be a tray of food, and then vocabulary is embedded within the familiar scene. There's some research that indicates that young children or children who are functioning at those earliest stages of communication oftentimes understand intuitively vocabulary in a visual scene display a little bit better than a grid display. And I think when we think of speech generating devices nowadays, I think many people first think of off-the-shelf tablet technology like the iPad or like the Samsung Galaxy. I'd say most of the kids out there who are using SGDs do use tablet-based devices, but there's still also quite a few dedicated devices that are out there. The way that these things are the same is that they both have large storage capacity, they both support language growth, and nowadays they really both have quite high quality voice output. So there aren't many devices nowadays that sound like Stephen Hawking's device with the kind of computerized voice output. They're usually quite realistic nowadays. The biggest difference between the two, and you can kind of see that difference in the name itself, is that a dedicated device is really used only for communication. It is dedicated for that purpose, whereas tablet-based devices can be used for many different purposes. Now, there are good things and bad things about that. You know, the good thing about it is that an individual might be able to use their tablet-based device to write emails, to interact with social media, to do other things in their environment rather than just communicate. The bad thing, or the drawback to that, is that sometimes when children are used to using a tablet for doing things like watching videos or playing games, it's really difficult for them to transition into seeing that device as a communication device and not as a toy. So what I oftentimes recommend for the clients that I see is if they already have an iPad and they're used to using it for playing, that perhaps they get a second tablet-based device and then that tablet is dedicated for communication purposes. Another difference is with durability. So dedicated devices are usually more durable than off-the-shelf technology. Of course, you can purchase things like protective covers and cases that can make tablet-based devices more durable, but the ones that are dedicated typically right off the shelf are going to be more durable. They also have better customer support. So most of the time when you go through a durable medical equipment company to purchase the device, if something were to happen to the device, you can send it back to the company. They'll send you a loaner device in the interim, and then they'll fix it and send it back as part of the warranty. Those of you who have an iPad know that, if your child throws the iPad and breaks the screen, you can't take it back to the Apple store to get a refund or to get a loaner device while it's being fixed. Dedicated devices, because they can only be used for communication, are oftentimes covered by insurance. Tablet-based devices, if they're off the shelf, are typically, although there are some instances when you can get insurance, but in general, they're not covered by insurance. Dedicated devices are often very expensive, whereas tablets, iPads are not cheap, but in general, they're less expensive than if you are paying out of pocket for the dedicated device. And then the other difference is that there are variable sizes with dedicated devices, whereas in general, tablets are quite lightweight and portable. So some of you might be thinking that one or two of these strategies may work well for your child, and you're wondering how to go about getting something like that. The first thing that you would want to do is have a comprehensive assessment. These assessments are typically conducted by the speech pathologist, although the speech pathologist is going to gather information from a wide range of sources. So from the child's family, their teachers, therapists, doctors. If your child has significant motor impairment, you definitely want to get the input of that child's OT or PT when it comes to things like seating and positioning and access. The speech therapist is going to review the child's strengths and needs. They're going to do some testing with the child. Some of this could be standardized, especially if the child's able to do things like point to a picture. However, much of the testing is going to be non-standardized, because when I do these types of assessments, I don't really care about a standard score. What I care about is what is the child able to do and what type of supports does the child need in order to be successful. The speech therapist is going to identify situations with the help of the parent where current communication is not cutting it. So whatever strategies they're using now, what are those situations when it's not sufficient to meet the child's needs? And then what you're going to do is identify solutions to meet the child's needs in those situations based on a principle called feature mapping. And that's where you take the child's strengths and their needs, and then you map that onto certain features of devices or onto strategies to figure out what's going to work best for the child. So throughout this process, the rule of thumb is that you fit the AAC system to the child, you don't fit the child to the AAC system. And I think that's important. Sometimes what happens is families who are very well-intentioned, or school teams, will go out and, for instance, purchase an iPad for a child, and then they might come to the speech therapist and say, you know, how do I get my child to use this effectively? And that's really not best practice, because what we want to do is say, you know, well, what does the child need right now? What are their strengths and weaknesses? And it could be that an iPad is the best tool, but it could be that something else is as well. So you always want to look at the child first. The second part to this are doing device trials, and that's where you actually trial several different devices and strategies over time. So you might use device 1 week, device 2 the second week, and then you actually take data about how well each thing works before you settle on a system that best fits the child's needs. Now, you're probably thinking a lot of these devices are expensive. How do we go about getting several things to trial over time? I know in Pennsylvania we have lending libraries in every county, and I'm pretty sure throughout the United States there are assistive technology resource centers. Most states do have some type of funding available for lending libraries through the Tech Act. So I've included a website here, at least in the United States, that should outline where the lending libraries are and how they're funded in each state. At that point, when you find funding, if you want to go through private insurance or Medicaid, you're going to need to submit the AAC evaluation, including that device trial data, to the insurance plan. Insurance typically wants a doctor's prescription or a letter of medical necessity. If you're going through insurance, what I would recommend doing is contacting the manufacturer of the device that you want, and most of those manufacturers have dedicated funding departments that can walk you through that process. The second avenue of funding for some children could be the school district. So if in the IEP it's written that a child needs a specific device and software in order to meet their educational needs, then the school district by law really should provide funding for that device. In practice, it does not always work this way. In my own experience, most districts do not want to write specific technology into the IEP for this reason, because then they know that they would have to pay for those things. So they tend to keep it more general. But I oftentimes tell families that the first thing that you should do is to ask your school district, because it's possible you could get something funded through the district. You can also look into low-interest loans or national support organizations. Two that I know of off the top of my head are Autism Speaks and the Childhood Apraxia of Speech Association of North America, or CASANA. They both have grant funding opportunities for families. And then lastly, you can look into local community service or charitable organizations, things like Kiwanis Club, Lions Club, etc. So some frequently asked questions. The first is, will using AAC prevent my child from learning how to talk? This is the question I'm probably asked more than anything else. So I'm happy to report that there's been quite a bit of research in this area, and it shows that introducing AAC will not keep your child from learning how to talk. I always tell parents, if your child's going to talk, they will. You know, introducing these strategies won't prevent it. There's actually been some preliminary evidence that certain children might have an increase in verbal speech after the introduction of AAC. So this shouldn't be the goal of introducing AAC, but in some situations you actually might see an increase in verbal speech. Another question I'm oftentimes asked is, how can children with significant physical disabilities access an AAC device? And I again put on here Stephen Hawking. If you think of Stephen Hawking, he has very limited use of his limbs. He's in a wheelchair throughout the day, and yet he's able to access a device. So technology is really amazing, and just in the last 5 years, there have been leaps and bounds and improvements for access strategies. We have eye gaze devices for kids who can use their eyes. We have switches, which can be activated by simply blinking an eye or twitching a chin. So even children with the most severe physical handicaps should be able to access an AAC device. Another question I'm oftentimes asked for many of my kids who are nonverbal or minimally verbal is whether or not their child has apraxia. Childhood apraxia of speech is something many of you may have heard of before. It's thought to be a disorder of motor planning and programming. The biggest thing to keep in mind is that when a child is minimally verbal, it's really not possible to reliably diagnose it. In order to reliably diagnose apraxia, you need to have a nice, robust speech sample, because what you need to do is analyze the way that a child is mispronouncing things. I'm sorry, I'm having difficulty with that word. However, I do know that that was a question that some parents had, so I wanted to provide some additional apraxia resources. There's actually a Simon's VIP webinar that I did a couple of years ago on speech sound disorders, and that included apraxia. I've included the link there. And then there's a really wonderful organization and website called CASANA, which is apraxiakids.org. They're the ones who have the iPad grant opportunities, but they have a lot of additional information about apraxia. What is it? How do you treat it? So I would strongly recommend any curious parents to take a look at their website as well. Another question I'm oftentimes asked is, will my child ever learn to talk? This is one of the most challenging questions to answer, I think, and it's of course difficult if I haven't met the child. But in general, I tell parents there really is no set age cutoff for learning how to talk. I think that's a common misconception. Sometimes parents will come to me and say, you know, well, my speech therapist told me if my child isn't talking by 3, they're never going to talk, or sometimes it's 6. And there really aren't any hard and fast rules. When it comes to HIVEP2, we're obviously still learning a lot more about it. We heard from families in the beginning that many children are talking, whether that's single words or phrases or sentences. It certainly, I think, is a possibility for kids. If your child's not talking now, it's certainly a possibility in the future. I would recommend to parents, regardless of whether or not they're using some words or not, AAC strategies might still be helpful. If you remember, AAC strategies, they're not just used for kids who are nonverbal, they're used for any child who maybe speech isn't sufficient in all situations. So I would certainly keep an open mind. I would implement things that are going to help your child functionally communicate now, regardless of whether or not they're going to eventually become verbal communicators. It's important that they have some type of strategies in place. You can start teaching them language skills that speech can then scaffold onto. Some final thoughts, and I think I'm running over, so I'm going to be pretty quick with this. There's no one-size-fits-all strategy. You know, something that works for one child isn't necessarily going to work for another, and that's why it's so important to have a comprehensive assessment. The second is that communication is multimodal. So there's no reason why you have to settle on just one AAC strategy. It's really going to depend on the situation and the individual child. Most kids that I work with do use more than one strategy. Maybe speech works some of the time, especially if your family understands you, but then maybe you go out in the community and you use another strategy as a supplement. You certainly want to keep the lines of communication open between families, teachers, and therapists. You really have to have buy-in from everyone who works with the child for these strategies to be used appropriately. And then the strategy is only as effective as the instruction program. So every strategy I talked about today, you know, it's not enough to simply show the child how to use it once or twice. It's going to be an ongoing learning process, both for the child as well as for the family and the school team. So it's something that a child is going to continue to learn over time, the same way a child continues to learn language over the time. And so because of that, of course, some time and commitment are going to be required on the part of the family and the school. These are some additional resources. If you want any more information about PECS or POD, I've included those there. The Apps for AAC website is really great if you're considering getting some type of a communication app for the iPad. And then if you have an iPad but you would like to use it for communication, the iPad Pinterest site that's listed there has some nice cases and covers and accessories that are things to keep in mind for individuals who might use the iPad as a communication device. Okay, that's the end of my presentation.
Are there any questions? No? Okay, very good. Thank you so much, Marissa and Narissa. That was really a lot of information. So again, we're audio recording this. We'll be posting this. So if there's anything that you heard that you didn't get to absorb everything first time around, we'll have it online for you soon. Okay, so I think we're going to move over then to Sid. Are you on the line?
Yes. Can you guys hear me?
Okay. Yes.
Great. So thank you so much. So today I'm going to talk about the medical management of neurodevelopmental concerns in HIVEP2 disorder. And thank you to those listening who completed the survey on developmental medicine concerns. I really, really appreciate it. I used this survey to focus my talk on certain key areas of concern for affected families. I don't have time to touch base on every single aspect of developmental challenges in this talk, but I'm happy to answer questions at the end and talk offline in more detail. And here's my contact information. If you would like to send me an email, feel free. Here is an outline of my talk. I'll present some background information. Next, I'll talk a little bit about language disorders. I know I don't want to replicate all that's already been discussed, but I just have 1 or 2 slides about language disorders. Talk about ADHD, anxiety and depression, restrictive repetitive behaviors, and aggression and self-injury. Finally, I'll wrap the talk up with some conclusions. Before I proceed further, some general warnings. So keep in mind that non-medication interventions can be just as effective as medication interventions, but in this talk, I'll try to focus on medications. The information I'm going to talk about here is a combination of anecdotal evidence, a combination of observations from taking care of some patients with HIVEP2, some individuals with HIVEP2 disorder, and also extrapolation from data from other neurodevelopmental disorders like autism, intellectual disability. In general, there is a huge, huge need for evidence-based research for neurobehavioral interventions in HIVEP2 disorder, which I'll address at the end of this talk. First, some background. As all of you know, HIVEP2 disorder is a genetic disorder associated with distinct facial features associated with a spectrum of neurodevelopmental impairment, including intellectual disability, autism, hypotonia, which means low tone, delayed motor milestones, and so forth. Behavioral features can include hyperactivity, aggression, and anxiety can also occur. So why is it important to address challenging behaviors and developmental concerns? The answer, I think, is pretty easy, pretty simple. These are things that affect the quality of life for individuals with HIVEP2 and their families as well. So addressing these concerns early on, whether that's through medications, through therapies, through other interventions, that can help long-term outcomes for the future. So it's actually no surprise that in the survey that some families completed, so in the survey, four families were able to complete the survey. 3 out of 4 families, or 75% of families, reported that their child was currently taking a medication to manage developmental or behavioral challenges. Let me spend a few slides just to talk about development because it's important for the understanding of this talk. So when I mention child development, what exactly do I mean? What exactly do I mean? So child development refers to a timed, ordered series of events or milestones that take place affecting domains such as motor skills, language skills, socialization, cognition or problem solving, and behavior. Neurodevelopmental disorders, then, are disorders that affect each of these domains in certain ways. And I just want to reiterate, these are clinical descriptions. So for example, if you have significant motor impairment, you may end up with the label or the descriptive label of cerebral palsy. And for genetic disorders like HIVEP2, I like to think of it as a CP-like presentation. If you have significant language issues or significant language impairment, you may end up with the descriptive label of a language disorder. If you have significant language and socialization impairment, that may lead to the clinical description of autism. If you have significant cognitive or problem-solving impairment, that may lead to the diagnosis or the label of intellectual disability. So behavioral problems can also result in different symptoms. So hyperactivity and inattention can lead to a label of ADHD. Anxiety, depression, repetitive behaviors, aggression, self-injury are also different kinds of behavioral challenges that occur. I put a star next to the different conditions, different things I'm going to talk about, focus on in my talk over here. So just to reiterate, this is a vast oversimplification, but I wanted you to get a general idea. So language was one of the areas of concern in the survey that some families were able to fill out. Language is very, very important because it's the primary way we interface with the rest of the world. I like to think of language as having two components, an expressive language component and a receptive language component. Expressive language is our ability to communicate, to get across thoughts and ideas. Receptive language, in contrast, is our ability to understand thoughts and ideas. And on one level, receptive language is somewhat like thought or cognition. It's important to view language in the context of cognition or thinking abilities. So look on the example on the left. So let's say you have a 6-year-old who has intellectual disability, who has an IQ of 50. So what you do is you take that child's actual age, 6, and multiply it by their IQ. So 50 would be 50%. So if you take 6 years and multiply that by 50%, you get 3 years of age. So a child who has intellectual disability without a superimposed language disorder, that child's cognitive abilities should be at the 3-year-old level, and that child's language abilities should be at the 3-year-old level. There's a match between cognitive abilities and language abilities. So in contrast, if you take a child who has intellectual disability plus a superimposed language disorder, so once again, look on the example on the right. So once again, we have a 6-year-old child who has an IQ of 50. So you take 6 and multiply that by 50. So that child's cognitive abilities should be at the 3-year-old level, so 6 times 50% are 3. But if there's the presence of a language disorder on top of the existing intellectual disability, that child's language abilities should be disproportionately affected compared to that child's cognitive abilities. So language disorders reflecting an impaired ability to communicate are a common challenge for individuals with HIVEP2, as you guys have heard. I like to think of 3 pillars for treatment of language disorders: one-on-one individual speech and language therapy, play in social groups where children learn to model language socialization from each other and from other kids, and then augmentative and alternative communication, which you heard about in great detail. I just have one slide on AAC. So as you guys have heard, augmentative and alternative communication refers to the use of different kinds of devices and techniques and strategies, allowing kids to communicate even in the absence of spoken speech. But I like the point that the absence of spoken speech is not a prerequisite for AAC. So these devices can be high-tech, such as an iToby device like this one, or they can be low-tech, such as a picture board like this. And AAC can be especially helpful for kids who are nonverbal, but it's not necessarily that you have to be nonverbal to engage and to use AAC. And I know that this isn't a medication per se, but it's a great intervention, and I recommend families look into it because there's a lot of potential communication abilities, and our goal is to kind of unlock that potential. Let's switch gears a little bit and talk about attention deficit hyperactivity disorder, or ADHD, which is a common feature of neurodevelopmental disorders, and HIVEP2 disorder is certainly no exception. In fact, in the medication survey completed by families before this talk, 100% of the 4 respondents said that hyperactive, impulsive, and/or inattentive behaviors were an important target for medication therapy. In terms of, so what exactly is ADHD? So ADHD is a disorder of inattention, distractibility, hyperactivity, and impulsivity. These symptoms have to occur in 2 or more settings, so home or the school, and they have to be functionally impairing, meaning they have to cause problems in the social environment, the academic setting, and so on. There are generally 2 approaches to treatment for ADHD, and both approaches are often necessary. A non-medication approach involves behavioral therapy, whose purpose is to provide parents and caretakers with strategies to redirect the child's behavior. Sometimes families think that behavioral therapy is targeted for the child, meaning behavioral therapy will kind of reroute the child's behavior, but actually behavioral therapy is more helpful for the parents, actually, and the caretakers, because it arms them with strategies to redirect behavior. If behavior therapy is not effective, then medications may be necessary. There are 3 main classes of medications for ADHD. There's methylphenidate products, which are stimulants. There are dextroamphetamine products, which are also stimulants. And then there are non-stimulant products. Treatment for ADHD often requires a trial and error approach. So usually I start with 1 class of medication, such as something from the methylphenidate family or amphetamine family. If that's not working, or if that has significant side effects, then I try something from the other class of medications. And if that's not working, then I try something from one of the 3 classes of medications that I haven't tried yet. In terms of kind of a general approach to ADHD medications, I've included some advice here. The first thing I wanted to mention is that I would recommend a start low, go slow approach. And what I mean by that is start at a low dose of whatever medication you decide, and then slowly go up on the dose. And the reason I suggest this is that the metabolism, or how you kind of process that medication in your body, the metabolism can be different for kids with HIVEP2 compared to typically developing children. Some of the main side effects of ADHD medications can include decreased appetite and disrupted sleep, but both of these have solutions, and you don't necessarily have to give up on a medication because of these side effects. Adderall specifically, which is an amphetamine product, so that can lead to increased aggression in some kids, as noted by one of the HIVEP2 families who completed the survey before this presentation. And I recommend that you wait at least 1 week before deciding whether a new medication or a dose change is effective or not. Really try to avoid the temptation to stop a medication early unless there are serious side effects. Your body can kind of take some time to get used to a dose change or a different medication. So there may be some side effects during the first couple of days that go away over time. So choosing which medication depends on your preference for a couple of things. So it depends on your preference for duration of the medication itself, or how your child can take a medication, what kind of form your child, what kind of pills, or whether your child can swallow pills, or whether your child has to have a liquid instead of pills, whether your child can tolerate having a patch, and so on. So within each class of medications, so I've listed methylphenidate products, I've listed amphetamine products, and I've also listed non-stimulant products. So within each class of medications, there are short-acting forms, which generally speaking last around 3 to 6 hours, give or take, and they're long-acting forms, which can last about 7 to 12 hours, also give and take. So they're short-acting and long-acting forms in the methylphenidate family. They're short-acting and long-acting forms in the amphetamine family, and they're also short-acting and long-acting forms in the non-stimulant family. So there are some pill options. So these are medications that you can't crush or chew. You actually have to swallow them whole. There are capsule options, which means that you can break open the capsule and sprinkle the contents onto applesauce or yogurt or some other food, and you can eat the medication through that food product. There are some pills that are actually chewable. So methylene chewable is an example of this. There are some medications that come in a liquid solution, which means that if you can drink the medication, you can take, if you can drink liquids, you can take that medication. And then finally, there are some medications that come as a patch, which you can apply onto the skin and have to change every week or so, depending on the patch. Among the survey respondents, one of the HIVEP2 families reported success with Vyvanse for ADHD, but that's only one respondent. Anxiety and depression could be another problem faced by a child with HIVEP2. Now, interestingly, in the survey that families completed prior to this talk, actually none of the families suggested that this was a problem. And my suspicion, though, is that it might be an under-recognized phenomenon, given that mood disorders are common among neurodevelopmental disorders. Anxiety and depression can have a variety of manifestations. So symptoms can include irritability, excessive worry, perseveration, which means kind of focus on something and not letting go of that thought, social avoidance. Sometimes anxiety and depression can be difficult to recognize, especially with increasing levels of intellectual disability associated with HIVEP2. As with ADHD, there are two approaches to treatment. There's a non-medication approach, and that usually involves seeing if there are triggers for anxiety or depression. There's also a specific type of behavioral therapy called cognitive behavioral therapy that can be useful for anxiety, but this may be less applicable to HIVEP2 because of the presence of intellectual disability. So often medications can be necessary or may be necessary. And I've listed 3 broad categories of medications used in the treatment of anxiety and depression. There are selective serotonin reuptake inhibitors, which include things like fluoxetine or Prozac, sertraline or Zoloft. There are other antidepressants, and these include things like serotonin and norepinephrine reuptake inhibitors, SNRIs, norepinephrine reuptake inhibitors, NRIs, and norepinephrine dopamine reuptake inhibitors, or NDRIs. You don't have to know exactly what those stand for. And there are also benzodiazepines, which include things like alprazolam or lorazepam, which you might also know as Xanax or Ativan. In terms of kind of broad principles for medications for the treatment of anxiety and depression in HIVEP2, once again, so what I would say is I would suggest kind of a start low and go slow approach. SSRIs, or selective serotonin reuptake inhibitors, are often first-line treatment for anxiety and depression, and a low dose of this medication can possibly help mood and anxiety states in HIVEP2. One caveat to this, one warning to this, SSRIs in some individuals can lead to worsening agitation, worsening and kind of activation of behavioral issues. So just keep that in mind. I would discourage the use of benzodiazepines for anxiety just because there's risk for dependency on those medications, and there can sometimes be paradoxical agitation, meaning you expect the medication to calm or to cause child to calm down, but it leads to the opposite reaction. I wanted to spend some time, just a slide or two, talking about a specific SSRI medication called fluoxetine, also known as Prozac. Fluoxetine increases neurogenesis, and neurogenesis is the process by which brain cells mature and develop. So fluoxetine increases neurogenesis in a part of the brain called the dentate gyrus, which plays a role in memory and learning. Now, interestingly, in one of the mouse models of HIVEP2, there are maturational defects in this region of the brain, in the dentate gyrus. Now, anecdotally, some families have reported on improvements in with use of fluoxetine in language and motor skills, and in fact, loss of language skills when it was withheld one summer. And I'll just read two responses from the survey. Fluoxetine increased developmental improvements in all areas, increased fine and gross motor control, increased attention, increased awareness of environment, increased communication. And another respondent indicated fluoxetine increased speech. So this medication may address not just anxiety, but possibly cognitive and motor features as well. Of course, we definitely need to, I think we need to study this in a lot more detail before we can come up with some solid conclusions. Okay, so now let's talk about repetitive behaviors, which is another area of concern for individuals with HIVEP2. In the survey, about 25% of the respondents suggested that repetitive behaviors were a worthwhile target for medical therapy. Restrictive repetitive behaviors include stereotyped motor movements, insistence on sameness, and compulsive and ritualistic behaviors. And these behaviors tend to occur in higher frequencies in individuals with autism and profound intellectual disability, both of which can occur in HIVEP2. Sometimes environmental factors can make repetitive behaviors worse. So for example, if there are increased social demands, that can lead to worsening repetitive or restricted behaviors. And sometimes having an underlying condition such as anxiety or sensory sensitivity issues, that can also make you more predisposed to having restrictive as well as repetitive behaviors. For treatment of repetitive behaviors, I would start with a low-dose SSRI, that select serotonin reuptake inhibitor class of medications. As I mentioned previously, SSRIs can lead to behavioral activation and worsening agitation in some, so just be aware of this as a potential side effect. And for really difficult cases where repetitive restrictive behaviors are leading to significant disruptive behaviors, one possibility is that you could, on top of the SSRI that's currently being used, you could add a medication that belongs to a family that is called a second-generation neuroleptic. An example of that is risperidone. And this is a kind of medication and a kind of class of medication that I'm actually going to talk a little bit more in detail in the next section, which relates to aggression. So aggressive behaviors can be quite challenging for some kiddos with HIVEP2. In the medication survey, 50%, so 2 out of 4 of the respondents said that aggressive, self-injurious, and/or explosive behavior was an important target for medication therapy. Aggressive, self-injurious behaviors include things like head banging, hand biting, excessive scratching, and so on. And understandably, they can be a source of significant parental distress for families affected. So they're pretty impairing. They can be pretty impairing for the child, but they can be quite distressing for the family and all caretakers involved. So they're important to address. So these behaviors, in terms of treatment, these behaviors require a full behavioral assessment. And the reason they require a full behavior assessment is because it's important to note if there are certain triggers in the environment that may be leading to these aggressive self-injurious behaviors. And then sometimes an undiagnosed medical problem can be the cause, or can certainly make aggressive self-injurious behaviors worse. So there have been kids who have not been able to communicate or express clearly sources of pain, such as reflux, cavities, ulcers, things like that. And treating those underlying medical conditions can really diminish aggressive self-injurious behaviors in some cases. Now, in terms of medications for aggression in HIVEP2, so there's a class of medications that I alluded to before called second-generation neuroleptics. And so these might be an option. Risperidone, or Risperdal is another name for it, is a prime example. Other second-generation neuroleptics include aripiprazole, Abilify, quetiapine, also known as Seroquel, and olanzapine. In some medications, a class of medication called, or some individuals, I should say, a class of medications called a mood stabilizer may be helpful. And this class of medications includes things like Depakote or valproic acid and lithium. I should note that the data in this sense is limited in general. One major caveat to this class of medications used for aggression, self-injury. So second-generation neuroleptics are really, really strong medications. So they're big guns, so to speak. And as a result, they have a lot of potential for some serious side effects. So these include things like metabolic syndrome, weight gain, elevated cholesterol, lipids, risk for diabetes, those sort of things. So they require close monitoring and close and careful monitoring. So let me just wrap things up with some conclusions. So there's a spectrum of neurodevelopmental impairment associated with HIVEP2, so including intellectual disability, autism, language disorder, cerebral palsy, or CP-like presentation. Often in terms of treatment, my approach generally is, let me identify the cluster or clusters of symptoms that are really impairing, and by identifying the cluster of symptoms, I can tailor the medication management accordingly. And some of you may be wondering, I didn't speak separately about autism, but part of the presentation of autism is repetitive restrictive behaviors and language impairment, both of which I talked about as kind of features of autism in this talk. And importantly, there's a great need to study what medications work and what medications don't work for individuals with HIVEP2. So I think medication surveys are a great idea, because we need to take all this insight from each of these families and come up with kind of some general consensus about what works and what doesn't work. So for example, in terms of kind of future research efforts that I'm personally interested in, one of the things I'm trying to do is kind of design a detailed survey and build upon what Marissa had already done, a detailed survey for families focusing on efficacy and side effects of different medications used for different indications, different behavioral indications in HIVEP2. And I'm also interested in studying the neurobehavioral phenotype of HIVEP2. So lastly, I just wanted to make a quick plug for the fact that I'm trying to start a HIVEP2 clinic at Boston Children's Hospital. So the goals of this clinic would be to optimize long-term neurodevelopmental outcomes and help coordinate specialty care across multiple disciplines. So the clinic would address neurological concerns such as seizures or other neurological issues, developmental behavioral concerns such as concerns for autism or global delay, intellectual disability, behavioral challenges like the kinds we talked about, sleep issues, although I didn't have time to talk about sleep, but that's certainly an area that can be quite challenging for some families. Educational concerns such as how do I navigate the IEP process, concerns about treatments like ABA therapy or other developmental services, and the clinic would partner with physicians in other departments for referrals and coordinations of care. And then there would be opportunities for research, including biobanking and so on. Finally, just to make some quick acknowledgments, so thank you to Marissa and all the other families out there. It's amazing seeing everybody kind of come together in this setting and us learning from everybody else. I'd like to thank Dr. Chung and the Simons VIP Foundation VIP project, and finally Dr. Mustafa Sahin, who's my mentor at Boston Children's Hospital. Thank you.
Thank you, Sid. Are there any questions from the parents? Okay, I know this has been a dense afternoon. I think I'm going to open this up for questions for anything at all for any of us who've spoken or anyone else who's on the line, comments to each other, but I'm going to open it up just for general discussion. And then after that, as I had said before, we will also get off the line. So if the families want to have any private discussion amongst themselves, then that's fine as well. And just remember, I'm not sure exactly what you have to do to get yourself off of mute, but it might be a two-step process.
Hello?
Hello.
Oh, good. You can hear me. Yes, it took me a little while to try to unmute myself. This is P1. My daughter is Eileen, and I'm sorry I got on a little late. I do have a question for Dr. Sid. It's around attention deficit. And thank you for the summary. Eileen has been on medications for attention deficit, and we've seen some of the, I'll just say, negative behaviors as a side effect of the stimulants. So we're actually going down the route of non-stimulants, and the thinking, we believe, is that with non-stimulants, there would be less or hopefully no, negative side effects. And I was just wondering from Dr. Sid if, from his work, his knowledge, and his experience with his own clients, does he have anything to share in that area that possibly has worked for other kids?
So thank you for that question. I will say that sometimes managing behaviors for ADHD for HIVEP2 can be quite challenging. And to my knowledge, I don't know of something that's been like particularly effective. I know that's just kind of extrapolating from the autism population. So I know that's not a one-to-one correlation, but sometimes guanfacine or 10X is a non-stimulant medication that has been helpful and has some also anti-anxiety properties as well. So that's, I'm not sure if that's an option that you've tried, but I think also in terms of side effects from these stimulants, I think it's also really important. Perhaps we can talk. I'm happy, send me an email and we can talk a little bit more. It's really important to kind of get a sense of what time you give the medications. When do you think it's on? So how long does it take to take effect? When does it start to wear off? Because there's kind of it takes some time for the medication to kick in, and it can also take some time for the medication to get out of your system. And that period of time, there can be kind of some irritability and things like that associated with it, but kind of talking through that and trying to get a better sense of what are the symptoms that are happening with the stimulant and what can we do in terms of tweaking the timing, et cetera. Those kind of things could be helpful as well. So the short answer is I don't know of kind of a great miracle, ADHD medication yet so far, which is why I think collecting data from as many families as possible is important. But then number two, perhaps, feel free to send me an email and we can have a separate phone call to talk about the more specifics of what has been tried and if there's anything we can do to tailor those trials to be more effective for Eileen.
Okay, thank you very much. And I have an additional question for you. You had mentioned, well, I guess there was part of your slide, and maybe I just kind of what I took away from the slide. So the question is that for our kiddos with this particular gene mutation, are there medications, like, I guess, that are connected, or the effects of it are connected to the gene mutation, or is it just, a medication is different in each individual? Not sure if that came out clear.
I think I kind of understood. Let me kind of give you some, I think what I think you're trying to get across that, and then let me know if that's clear or not clear, or if you could rephrase the question. But I think, meaning like, is there something in terms of like the mechanism of disease that could suggest one class of medications may be more effective than another? Is that fair to say?
Yes, thank you. I'm glad you can read my mind.
Okay, sure. So I had two thoughts about that. So one, and this comes from one of the papers that was an animal model of HIVEP2, and in that animal model, and this paper was kind of talking about it was actually presenting the animal model as kind of a model of schizophrenia. So it's a little bit, unrelated, but it was still kind of focusing on the gene defect, and kind of the paper was trying to suggest that some of the behavioral issues that I think it was a mouse or rat, that some of the behavioral issues the mouse or rat was demonstrating was kind of like a schizophrenia-like presentation. But ignoring aside the fact that sometimes going from an animal model to a human can be quite challenging, and sometimes and often there's not exactly one-to-one comparisons. But ignoring those things aside for the moment, in this paper they demonstrated that using neuroleptic medications, and these are medications that I mentioned that include things like risperidol. So using neuroleptics actually kind of decreased some of the kind of inflammatory issues that were going on in that mouse model, and decreased some of the behavioral abnormalities that were going on in the mouse model. And once again, neuroleptics are potent medications, and they're big guns, so to speak. So it's not surprising if they're kind of significant behavioral issues. It can kind of quote unquote knock those behavioral issues down, but that there's always a risk-benefit profile or risk-benefit analysis that comes with that. But the second point I wanted to convey was, and this relates to fluoxetine. So neurogenesis, which relates to the ability relates to kind of how brain cells develop and mature. So neurogenesis in a particular part of the brain, the dentate gyrus, is affected. And although people haven't demonstrated in the mouse model that if you give fluoxetine, which increases neurogenesis, that it will improve outcomes. It's interesting because there's separate data unrelated to the HIVEP2 literature that suggests that fluoxetine can improve neurogenesis. So there's this theoretical, hypothetical consideration that perhaps fluoxetine, which is an SSRI, perhaps fluoxetine may increase neurogenesis, which is the development and maturation of nerve cells. And by doing so, you improve the kind of developmental and language and motor functioning. And once again, that's a pure speculation hypothesis at this point. There's some of the responses from the survey suggest that fluoxetine may be helpful, not just for anxiety, but for language and things like that. But once again, this is a theoretical consideration, and I think we need to kind of think about that and study that a little bit more before making like a proclamation that this is entirely effective.
Yeah, and actually for us, it's beyond theoretical, because we are the family that actually took her off during the summer, and it was just, it was immediate. We put her back on, and she started talking again. And we actually did this twice, because we're both curious folks, and we do these crazy experiments, but it really proved to us that it was effective, at least for Eileen.
Right. And I think there's certainly kind of some one could make a biological argument for why that's leading to improvements. And once again, as with science, scientists, we like to be kind of methodical and hypothesis driven and so forth. And I definitely think this is something that should be studied further.
Thank you.
Thanks.
Any other questions? I'll just make sure people have a chance to get off of mute if they want to.
This is Marissa. I was curious if you guys feel, and this is a question for Dr. Sid and Dr. Chung, if there's any new information that hints to the effects of a HIVEP2 mutation affecting immunological concerns. I know that we have one patient that has complex immunological issues, and some of the children end up with chronic sicknesses, and just curious if you guys had any additional thoughts on that.
So at least this is Wendy Chung. At least what I've seen so far hasn't been, as you said, Marissa, with the one exception, a consistent immunodeficiency or recurrent infections or unexpected infections or things like that. And the kids are getting old enough that if it were at least going to be a very serious condition, we would have seen that. So even though, as I think the families know, this was originally, named in terms of the gene because of its relationship with HIV as a virus, I think sometimes we don't always know truly how this is involved. And I'm not, the good news is I'm not seeing a lot in terms of immunodeficiencies. It's still early days, but, I'm not seeing a big link yet.
And the only thing I would add is that we haven't looked, perhaps there could be, if you looked at blood levels of different immunoglobulins and things like that, there could be low levels of certain things, but it doesn't necessarily, but so far, as Dr. Chung was suggesting so far, it doesn't necessarily mean that translates to kids getting sicker with bad infections, that sort of thing. So, there could be two things at play. But the good news, as Dr. Chung suggested, is that immunological problems leading to serious infections doesn't seem to be a big concern.
Okay, great. And I just wanted to add also that as a parent, it was really encouraging for me to see the results from the communication survey. And I know that one of the things that I struggle with is we get this kind of generic information, which is still great, but in the papers, that child started speaking at this age, and but we don't really get rich information. So I think it was fabulous to hear that some of our children are reading and spelling words and printing the alphabet and writing their name. It's just really helpful for all the families, and especially the families with younger children and newly diagnosed, to hear the level of achievement that some of the children are seeing. So thank you for putting that together.
I agree. The kids are superheroes. They, with a little bit of help and a little bit of support, I think they're going to surprise us all. Any other questions?
Hi there, this is Lindsay Paisley. At the beginning of the presentation, there's a list of all the changes in the genes. And some had the P at the beginning and one didn't. Can you remind me what that meant again without the P? Or was that significant?
You know what it was? It was a typo that I forgot to put the P in.
Oh, okay. Okay.
Good that you caught my mistake. Any other questions?
So that would mean that there's actually there is a duplication of the actual gene misprint then.
Let me go back and just look exactly. Hold on.
Because I was going to ask the same question because Ryan, my daughter, is one of the ones with the R943X. And we thought we had a duplication there, but then when you list it without the P, I thought, well, maybe I don't know genetics that well, so maybe there was.
Yeah, so the last couple of them, I didn't put the P in if anyone goes back to look at those slides. So the last one is similar to the other ones with an X at the end, and the penultimate, the second from the last one, has what we call a frame shift mutation, which effectively does the same thing. So in fact, all of this, there's actually only one of you out there. D397Y is the only one that's kind of on its own. Everything else, I think, is probably, it's a guess, but my guess is acting more the same than acting differently, if that's making sense.
And I'd just like to pipe up that this is Marissa, and we are the Y, ending in the Y, and honestly, I do feel like Corinne's symptoms are very much similar to what the rest of the children experience. So,
and I should say there's a lot that we don't know about how Kieran's, we call it an amino acid substitution, how his one-letter substitution is affecting things, but it could be that it's exactly the same as everyone else. We haven't, we're early days and we haven't done any direct, what we call functional studies to see how the gene is functioning. Okay, other questions?
This is Lindsay again. I have one more question about fluoxetine. Our son Pierce is not on it currently. I'm just wondering, long-term side effects, say he was on it for, 5, 6, 10 years and then goes off it. Are there known long-term side effects, or will he get like really depressed? Or I don't know if this is an appropriate question for this setting or not, but.
Sure, yeah, so fluoxetine, so of all the different SSRIs, fluoxetine has been studied probably the longest in children. So there's a lot of data on the safety of fluoxetine in children. And in general, it's a pretty safe, well-tolerated medication without any kind of permanent, long-lasting side effects. In terms, I didn't mention kind of some of the others. So I mentioned as kind of some of the shorter-term side effects, activation, behavioral agitation. There's sometimes you can have what's called a serotonin syndrome, which is a serious which can be a serious side effect from use of medications like fluoxetine. But that's usually because there can be fluoxetine or another SSRI used with another medication that kind of increases the level of the fluoxetine. But generally, kind of long-term data suggests that it's pretty well tolerated and safe in children. Of course, there's no data whatsoever in kids with HIVEP2, but that's not atypical for kids with rare genetic disorders.
Okay, any other questions? Okay, I just want to thank a very special thank you to Lindsay Kartner, who did an amazing job putting everything together today, Jennifer Chernagle. There are a bunch of folks that actually aren't on the call, but that were very helpful in terms of putting the surveys, getting the data together. So thanks to Alyssa and also Leanne back at the Simons Foundation. And then thank you very much to Marissa and Narissa and Sid, all of you. It's been just great having everyone together and being able to give so much input for the families. I hope it didn't feel too overwhelming to get so much information, but as I said, we're going to archive this. You can come back to it as many times as you like. And my hope is that the community gets larger, that I hope we make this an annual event in some way or another, and hopefully our numbers grow over time. I will say that there are many other people, I think more kids getting access to the type of genetic testing that your kids got access to. So I'm hopeful that those numbers will increase significantly in the next few years. So I think, Lindsay, we're going to drop off in terms of all the different professionals. We're going to keep the line open. You can all unmute yourselves, have a conversation. Hopefully there won't be too much echo or things like that. And then, at some point, we probably won't keep the line open more than an hour, but we'll keep, Lindsay will shut off the line. Again, we will stop recording as soon as I get off, so none of your conversations will remain private or confidential. And if you don't need, much time or any time to talk, that's fine, just hang up. But we just wanted to keep the line open for you. So thanks, everyone. It's been a lot of fun. And as I said, I hope someday we'll get to meet face to face.